Hello here. Dr. Leon Lewandowski, President of Lion Advisory Group, Inc., and also its affiliate, its pro bono affiliate, the Polypharmacy Screen Senior Health Services. We're located in West Hampton, New York. I'm applying for the grant from the New York Digital Health Accelerator, particularly on the basis of seeking access to feedback from the leading healthcare providers in New York State. And again, this is a pro bono visitation home service up to date, and what we'd like to do is to take this into a real business. The service, the home visitation program, is designed for the minimization of prescription drug products in the elderly, and for establishing an accurate and secure electronic database, thereby keeping the elderly out of expensive hospitalizations. Now, why is all this necessary? In the old days, everyone had a physician who did all the prescribing of medications, the evaluation of any side effects, et cetera, et cetera. It doesn't work that way anymore in the last 15 or 20 years. What we have is what I call the cascade of multiples. We start off with multiple years, aging. We then proceed to, as part of that aging, chronic multiple health conditions. So multiple years, multiple chronic conditions. In the old days, at least, we had one physician, but not anymore. Now we have multiple physicians who, in order to show that they're really providing some service, usually give a medication. So now we have multiple physicians prescribing multiple medications, and very often those are delivered through multiple pharmacists. And what happens is that under a multiplicity of medications, and by the way, that's why we're called the Polypharmacy Screen Senior Health Services, polypharmacy, taking a multiplicity of medications, and senior health services, because we're really talking about the elderly, those usually on Medicare, i.e. over 65. So what we've become now is that the proposal is that the polypharmacy screen personnel really take the place of your old-fashioned physician, who was an overseer of your medication, an overseer of how you were doing on all these medications. Now, it's no secret that in the U.S. healthcare system, it itself is in dire need of some health care. The goal of our efforts in the polypharmacy screen and elsewhere must be to improve the care delivery, but lower the cost. And in New York State, there's really a third, almost side effect of being able to improve health conditions at lower cost, and that's, in our case, providing jobs for people to go into the role of healthcare guardian screeners. Now, we talked about the polypharmacy screen, and it really evolved probably 6 years ago when, as a kind of a hobby, I decided that I would get involved with care of the elderly locally. The thought then was that we would then be able to develop a cadre of physicians and nurses who could really, under the fee-for-service, the current fee-for-service rules, apply for payment. Well, it didn't work out that way, because when I applied to the Medicare procedures, the Medicare service, they said, well, it's not listed, it's not considered preventive care. And the only preventive care, by the way, which is now included in this type of care of polypharmacy, or even close, is the consultations, the paid consultations that are allowed for someone who's under alcohol treatment. So right now, even though the fee-for-service practice is probably on its way out, which could be a good thing, to be replaced, by the way, by a capitation. The current healthcare law calls for the replacement of fee-for-service with a capitation, i.e. the physician, hospital, the caregiver being able to lump together a group of people and say, well, we're going to take care of 1,000 people at X dollars, and Medicare will cover that, and we will cover the full health care concerns of the patients. Now, our program is EMR optimized already. When we go in and present ourselves to the patient, we do use some IT, we do use some EMR optimization, but it's a very simple program that we take from the emergency medical service. It's a 2-page sheet. It's called the Vial of Life. And one of the hopes is that we'll be able to improve data capture, storage, et cetera, from the other grantees with their improved, hopefully their improved presentation of how to capture data, how to retain it, and so on. What our service really is, however, is centralized around healthcare provision, healthcare managers. And the service really has to do with the selection and training of the appropriate people. So for example, when I give my polypharmacy screen presentations and we try to enroll a class, usually of nurses, and they have to be licensed in some form in New York State, what we do is we select those people who, based on a questionnaire that I've been able to put together, have a sense of empathy for the patient. They have the feeling that of trust. They can generate the feeling of trust when they go into the home. This, I can't stress how important that is, that whoever goes into the home, representing whether it's the healthcare provider, a hospital, a nursing home, et cetera, they have to be able to be a person who has that sense of being able to have a good, equivalent to a good bedside manner. That they have to empathize with the patient, there has to be a sense of compassion, they have to be able to interact not only with the patient but with the caregivers who are part of the household. And we always insist that it's either a family member or some educated caregiver locally. We do things in our training process like going through games. One person plays the patient, one person plays the trusted health caregiver. So it's this kind of role playing that really does help in advance. Again, the key to this is not the IT component, but really is the methodology of training the personnel and having those personnel go into the homes, creating an atmosphere of trust. It's amazing how if there's not a feeling of trust, we simply won't get the appropriate data. We won't get it accurate, we won't get it all. I think then that our program really has 3 goals, again, as outlined by the NYDHA. That's to provide better health care at a markedly reduced cost, and finally to provide jobs for those of us in New York State. Let's talk for a moment about the amount of savings. The numbers are staggering, and it's not all in fraud. There's a component of fraud always throughout the whole system, but it's just in wasted effort, things that really weren't necessary. And those numbers thought to be in the whole of the Medicare system range as high, the estimates range as high as $1 trillion a year. Now, what we have is the government and the insurance companies really wind up paying on the basis of healthcare delivery. And of course, by improving healthcare delivery, what we do is we lower taxes, we lower our insurance premiums. So it really is a system that has to be changed. We just can't afford the current fee-for-service anymore. We can't afford to have healthcare running amok. And it really is the driving force of our national debt. I ask you to consider, even though this is not a strictly IT presentation, the benefits of the old story of garbage in, garbage out. What we don't want is to overload the system with fact. What we want is a trained person going in, reviewing the health care of the individual patient in a very comfortable, meaningful, compassionate way, such that you get accurate information, and you only get that information that's realistically pertinent to the health of the individual, to the better health, the improved health, the continued good health of the patient. So our grant application has been filed. It takes the format of the application as presented, but in addition, I took the time to put together a précis of sorts of the grant application in a Word package, because I think that the way that I presented it actually reads a little bit better than trying to garner information from little boxes. So I would ask you to have available and go through the packet of the application, but also to take the time to look at the 4 or 5 page Word document, because it really does follow in a way that I hope gives a big picture of the entire healthcare situation and how it's time with small, simple approaches that we can start to attack this problem. Why the elderly? Because it's a good population. The amount of money spent in Medicare is staggering. And in fact, if you look at things like end-of-life care, the end-of-life care in the elderly, which always ends in the same end, which is death. The end-of-life care is just humongous in terms of an unnecessary cost to the system. So I ask you to look at the grant, to review it with an open mind. It's not strictly IT, as many of the grants will be, but we're looking at the procedures, the human procedures, getting the right people, getting the right presentation to the customer. In this case, that's the patient. We ask you to consider it and factor that in as the appropriate way of data collection in a secure manner. Thank you.